everybody. Thank you for being here today. Got some really interesting new information that I'm happy to share with you. At least it's new information to me, and I hope that it's going to be new to you as well. So we're going to be talking about our favorite little molecule, neurotransmitter hormone, melatonin, which we know to be the master regulator of the circadian system. That's a well-known aspect of melatonin. And this is what we think of usually when we're thinking of melatonin, that 24-hour period where during the day the light inhibits the melatonin production from the suprachiasmatic nucleus of the hypothalamus. And at night in darkness, melatonin reaches its maximum level in the middle of that 24-hour period, usually between 12 and 3 a.m. But now we're realizing that this image that depicts the circadian control of melatonin merely scratches the surface of the impact that melatonin has on the human body. This only represents about 5% of total body production of melatonin. Let that sink in for a second. That was a big realization for me. Melatonin is produced from the serotonin pathway once 5-HT or serotonin is formed from tryptophan and 5-HT. So in the absence of light, the enzyme N-acetyltransferase, NAAT, attaches an acetyl group to the indole portion of serotonin to form N-acetylserotonin. And then the HIOMT enzyme catalyzes that final reaction, converting N-acetylserotonin into melatonin. Now, remember, this part is happening in the darkness. The ancients used to say, as above, so below. So here you can see the rhythms of cortisol in black and melatonin in red, and how they're directly related to the influence of light and darkness. So here is the dim light melatonin onset that starts right about the time that the sun is setting, and that it starts the increase of melatonin to reach its spike in the middle of the night, and that DLMO is going to inhibit cortisol. The cortisol is going to remain low throughout the night, and then in the morning when it starts to increase, as we start to wake, the melatonin will be reaching its lowest level. And here you see the overlapping daily rhythm of temperature in red and how it's ruled by melatonin in blue. Again, as melatonin levels start to ascend in the early evening, the body temperature, this red, begins to fall, ultimately reaching its lowest temperature in the middle of the period, the sleep period, when melatonin levels are at their highest. And then in the morning, as cortisol starts to rise, then core body temperature starts to rise as well. And this is a depiction of how the suprachiasmatic nucleus of the hypothalamus detects and entrains the 24-hour light-dark cycle for all the cells of the body. So that middle of the night release of melatonin induces a shift from daytime to nighttime functioning, such as decreasing blood pressure, slowing down metabolism, and reducing body temperature at night. And of course, the opposite happens during the day when light suppresses melatonin and physiological rhythms shift to daytime functioning. This form of melatonin from the pineal gland is considered releasable due to its systemic availability. It communicates with virtually every cell of the body. And this is a simplified image of a 24-hour circadian cycle where you can see where certain physiologic functions naturally happen at specific times due to the interplay of melatonin and cortisol, light and dark. So note that when melatonin peaks, it's when most of the immune modulation takes place, as well as TSH and growth hormone. And then in the morning, with the rise of ACTH and cortisol, comes epinephrine to help us get out of bed, and testosterone. And as the day progresses, blood pressure and heart rate increase. And then when body temperature reaches its peak around 6 p.m., insulin, cholesterol, and triglycerides are at their peak, at which point they start to fall as well. And here's another model to show you how decreased sleep impacts inflammation. So we're looking at a 24-hour period here from from 20 hours to 20 hours. So 10 p.m. to 10 p.m. In this gray shaded area here is the sleep period. And then you're seeing on the left that arrow, these arrows here, outlines of arrows, are showing us what the expected homeostatic levels of these hormones are during sleep. So we've got hormones on the left, and we've got inflammatory mediators on the right. So you can see that during sleep, during the gray period, we expect growth hormone to be quite high, and that's this dark black line here. But if one is not sleeping during the sleep period, growth hormone is much lower, this lighter color, this lighter line here. Prolactin, same thing. We expect that nice peak during the middle of the night, but it's going to be attenuated when one is awake. Cortisol is going to have a little bit of a shift, not too much. Epinephrine, a little bit of a shift as well. Norepinephrine is going to be quite increased if one is awake in the middle of the night instead of asleep. And over here on the right-hand side, we've got our inflammatory modulators, and you can see interleukin 6 stays about the same, but look at TNF alpha, how low that goes when one is awake, as well as interleukin 12. Both of these interleukin 12s are going to be quite low if one's awake. And then interleukin 10, which should be low while we're sleeping, is going to increase. So an inflammatory cytokine. So another cruel trick that happens after a night of partial sleep is that cortisol levels are 37% higher the following evening. So after one has had an all-nighter or had very little sleep the night before, their levels are going to be 45% higher the next day. So not getting a good night's sleep can interfere with your ability to sleep the next day. So here you see that bigger picture, the representation of melatonin's effect on the entirety of the human body, and how pineal melatonin is widespread throughout the body. It's going to impact so many aspects of health: brain, retina, skin, liver, kidney, thyroid, thymus, skeletal muscle, and reproductive organs. Melatonin is present in most body fluids, including amniotic fluid, breast milk, cerebrospinal fluid, feces, synovial fluid, saliva, and urine. It's considered an amphiphilic molecule, which means that it has both polar hydrophobic and nonpolar hydrophilic regions, which enables it to cross all morphophysiological barriers, such as the blood-brain barrier, the placenta, and all cells of the body. Serum melatonin concentrations vary throughout the life cycle. Infants younger than 3 months secrete very little melatonin, and it gradually starts to increase, reaching its highest point between 1 and 3 years. After that, it starts to decline gradually, about 10 to 15% per decade. Note that puberty occurs right as melatonin begins that decline. And then you can see that as we age, we're producing negligible amounts of melatonin. And note that this negligible melatonin is tied with mitochondrial dysfunction. So one common factor in sleep problems is low vitamin D, which has been linked to difficulty falling and staying asleep. So consider testing and correcting vitamin D levels when someone is having sleep issues. Another interesting way to look at this is melatonin as a deficiency of the dark, as vitamin D is a deficiency of the light. So along those lines, there's an excellent new article that suggests that as vitamin D is an essential nutrient of the light, melatonin is an essential nutrient of the dark, both playing essential physiologic roles, both having hormonal actions, antioxidation, anti-inflammation, immune modulation, mitochondrial regulation, and system-wide effects. So one really cannot sleep well and get the benefits that they need from sleep if they are not being exposed to darkness. So here are some properties of melatonin: regulating the reproductive processes, hormone synthesis, activating the immune system, protecting the skin from UV radiation, antioxidant and cytoprotective effects, slows down the aging process, involved in hematopoiesis, it's cardioprotective. Now, of course, this is what we expect from mammals, but look what we've got here. Also, plants produce melatonin with some very similar qualities, regulating the circadian rhythm, maturing fruit, promoting seed germination, free radical scavenging and UV protection, defense against apoptosis, regulation of reproduction, and protection against oxidative stress. And of course, it's from plants where we get phytomelatonin, where we're going to be talking a lot about in a bit, and then phytomelatonin versus synthetic melatonin, which is more of a bioidentical to mammalian melatonin. And this is a graphic of some of melatonin's physiologic qualities: immune defense, circadian regulation, antioxidant, metabolism regulation, oncostatic properties, neurogenesis, and anti-inflammatory. So let's see how all these qualities translate into clinical practice. So we're going to be talking a lot about the mitochondria in this presentation. Why? Well, because of its location in every cell of the body and the important role that it plays in all physiologic functioning. And we're just starting to realize the impact that melatonin is playing on mitochondria. So mitochondria is the preferential site of synthesis for both ATP and reactive oxygen species generation because of the presence of the electronic transport chain. It can both take up, the mitochondria can both take up pineal-derived melatonin from circulation, and it has the ability to produce melatonin in a non-circadian manner. So they call this non-releasable melatonin. So pineal melatonin is releasable and systemic, and mitochondrial melatonin is non-releasable, and it's more serving an autocrine or a paracrine function. Mitochondrial malfunction can have debilitating consequences, and the mitochondria is dependent upon melatonin as a potent antioxidant. This image shows melatonin's impact on mitochondrial cells, where melatonin is found at a greater concentration than it's found in blood. Again, because remember, blood melatonin is mostly pineal. Mitochondria are the major source of intracellular free radicals, which are byproducts of normal cellular metabolism, and they cause oxidative damage that can alter mitochondrial function. Inside the mitochondria, melatonin is a direct scavenger of free radicals, and it stimulates antioxidant enzymes such as superoxide dismutase and glutathione reductase. Each of these enzymes then participates in the maintaining of the oxidation, reduction, homeostasis of mitochondria, and as they're acting as good scavengers of the reactive oxygen species. And now we know that mitochondria can produce its own melatonin for these purposes as needed, but we are also realizing that the cell is dependent upon pineal, that the mitochondria is also dependent upon pineal melatonin in order for it to work properly. So melatonin is synthesized in, taken up by, and concentrated in the mitochondria, which is the powerhouse of the cell. So it is both receptor dependent in terms of MT1 and MT2 receptors. Those are melatonin receptors to take up pineal and exogenous, so like supplemented melatonin. But because of its amphiphilic nature, it's also receptor independent because it's able to cross the cell, organelles, and the nuclear membranes and directly interact with intracellular molecules. And so in that way, it's not receptor dependent. So this larger pink square, this big pink square here represents a cell, and the smaller orange rectangle is a close-up of the mitochondria inside the cell. So you can see how the mitochondria produce melatonin in an autocrine fashion for the cell's use. And also it acts on other organelles within the cell. But it also has a paracrine nature in that the melatonin is released from the cell into the cytoplasm, and it can then be taken up by an adjacent cell. So it not only has that autocrine, it also has a paracrine quality. So let's talk about how this is going to show up in some other, in clinical practice in some other parts of the body. So the pineal gland and the GI tract are the tissues that produce the most melatonin. The gut represents melatonin's most abundant extrapineal source with a 400x higher concentration than the pineal gland. Now, it's working locally, not systemically. So the bidirectional arrows that you're seeing here are showing conditions that are associated with dysbiosis and low melatonin, where therapeutic melatonin has been shown to modulate the microbiota and improve symptoms. Melatonin and the colonic bacteria work synergistically to maintain this systemic homeostasis. And so in this slide, we're going to be looking at the more specific finding around sleep disorders and melatonin's beneficial systems and GI effects. So we're going to be looking below this blue line here is the gut, above this blue line is systemic effects. So below the line in the gut, melatonin reestablishes the intestinal microbiome by increasing beneficial and decreasing pathogenic bacteria. It restores barrier integrity by increasing tight junction proteins. It reduces oxidative stress by increasing levels of antioxidant enzymes such as glutathione, peroxidase, superoxide dismutase, and total antioxidant capability. And it diminishes the inflammatory state by decreasing pro-inflammatory cytokines and increasing anti-inflammatory cytokines. At the systemic level above the blue line, melatonin reduces stress hormones such as corticosteroid and norepinephrine. It decreases systemic inflammation by contributing to decreasing inflammatory cytokines, and it restores glucose homeostasis by decreasing glucose level. And so here you see how the lack of sufficient pineal production of melatonin from sleep disruption can inhibit extrapineal melatonin production in the gut. So on the left is a normal circadian rhythm with a hearty melatonin spike here associated with darkness and sleep, which sends melatonin via the bloodstream to the gut bacteria and to enterocytes, serving as an anti-inflammatory, anti-tumor, and antioxidant, enabling the enterocytes and the bacteria to produce extrapineal melatonin, which then feeds back to the pineal gland. Okay, so this is that feedback here. Melatonin from the pineal gland and feeding back from the pineal sites and the bacteria. On the right is an example of chronodisruption, where sleep is impaired by light or work or alcohol or someone snoring or fill in the blank, where that hearty spike doesn't take place. Instead, you're going to have an attenuated spike, or maybe you'll even have two smaller spikes. So it's going to lead to low blood levels of melatonin and insufficient melatonin to prevent inflammation in the enterocytes, which is going to lead to oxidation, potentially to tumor growth. It's going to disable that feedback loop back to the pineal gland, and it's going to impair bacterial melatonin production. So you see this nice dark line creating this nice loop with this healthy melatonin level. And then, oh, sorry about that. And then you see this lighter line here, both in terms of the production of melatonin from the pineal gland, and then also this feedback loop also being attenuated because of chronodisruption. So this is a depiction of parallel inflammatory mechanisms that lead to insulin resistance and glucose intolerance that's associated with the cognitive dysfunction of Alzheimer's. So the dotted line represents the brain above and the periphery below. And it's showing the connection between increased brain reactive oxygen species and inflammation that contribute to insulin resistance and decreased melatonin levels. Below the line, you can see how adipose tissue associated with type 2 diabetes produces the same inflammatory cytokines that can cross the blood-brain barrier and interfere with the circadian rhythmicity of the pancreas, which is mediated by melatonin receptors. The disturbance of this system induces glucose intolerance and insulin resistance in the periphery and in the brain, which has been shown to be restored by melatonin supplementation. And this is a really complex slide that I'm not going to go into great detail, but I wanted to provide it for you if you want to understand a little bit more the biochemical processes that impact the signaling pathways of beta cells. So you have that here if you want to go into that just a little bit more closely, how melatonin plays a role there. So these are all diseases that are associated with abnormal mitochondrial dynamics. Alzheimer's, Parkinson's, ALS, Huntington's, epilepsy, schizophrenia, MS, neuropathic pain, muscular dystrophy, Lou Gehrig's disease, diabetes, and cancer. Many of these also associated with diseases of aging when mitochondrial levels are very low and melatonin levels are low. So I think it's really important to understand this kynurenine pathway. 95% of tryptophan is metabolized by this pathway. It's essential for converting tryptophan into nicotinamide, here, NAD+, for cellular energy. But this pathway becomes derailed or hijacked by inflammation, which activates elevations of indoleamines, IDO, which pushes too much tryptophan toward this pathway, leaving less for the serotonin and melatonin pathway. So when this happens, it can form neurotoxic quinolinic acid, which is associated with depression, and also in addition to inflammation contributing to this pathway, also low levels of melatonin are going to push this pathway. And this kynurenine pathway and quinolinic acid is associated with many neurological disorders, such as dementia, Tourette's, tic, MS, Huntington's, but also HIV, lupus, and long COVID. B6 deficiency is also playing a role here and could help to support the serotonin melatonin pathway. As well, exercise is one of the best ways to push toward the serotonin melatonin pathway and away from the kynurenine pathway. Major depressive disorder, schizophrenia, and bipolar disease are all associated with increased light exposure during the sleep period and less availability of serotonin and melatonin due to pro-inflammatory cytokines, which push the neurodegenerative kynurenine pathway associated with these degenerative processes. The melatonin in the cardiovascular system has been shown to regulate the heart rate, reduce blood pressure in patients with hypertension, diminish the risk of developing reperfusion injury after myocardial infarction, and all of this is due to melatonin's free radical scavenging, reducing oxidative stress qualities, as well as its ability to modulate metabolic activity, regulate cytokines, and prevent apoptosis. So a little bit more going into melatonin and blood sugar regulation. Melatonin signaling regulates the daily rhythm and blood glucose levels related to MT1 and MT2 receptors. Those with knocked out MT1 and MT2 receptors lose their glucose rhythm. Fluctuations in glucose concentration are dependent on the suprachiasmatic nucleus, and they're independent of feeding rhythm. So it really is the circadian rhythm that is controlling these MT1 and MT2 receptors and their ability to modulate glucose. In this way, the suprachiasmatic nucleus is thought to play a role in preparing for the upcoming activity period by increasing plasma glucose levels and facilitating tissue glucose uptake. Okay, so what do we mean by that? What does that look like? So this is showing you how this is a 24-hour period. On the left, we've got 7 a.m. On the right, we've got 7 a.m. And it's showing you how melatonin levels decline over the first few hours after awakening and how they are going to increase in the last hours prior to sleep on the right, creating two windows of risk if one eats during those times. So there is a common melatonin receptor variant. It's called MTNR1B. It's associated with increased fasting glucose levels and type 2 diabetes, and it amplifies melatonin signaling due to increased receptor expression. And so we're seeing that variant here with this dotted line, okay? So you can see, control here without that variant, without that melatonin receptor variant. And here you're seeing what happens to melatonin levels when one has that variant. So someone with this variant could have elevated melatonin levels while they're eating, leading to impaired glucose tolerance. As well, a very early blood draw could mean that melatonin levels are still present, which is going to impair glucose control. If melatonin is given to this population, their hemoglobin A1C levels need to be monitored closely. And so this variant tends to be more common in European, Asian, and Native American ancestry. So when I look at this, what jumped out to me is the importance of time-restricted feeding, or just not eating during the sleep periods. Being aware of how those sleep periods, melatonin levels are going to be higher, it's going to be impairing blood sugar regulation, and how this is a better time for us to be eating in here. Right when we've got this, when melatonin really hits its nadir in the morning, and right up until it starts to increase with the dim light melatonin onset. So because of the Warburg effect, which is the increased rate of glucose uptake and more inflammation during the daytime functioning of cells, melatonin should be prescribed during the day for cancer treatment. It can be given with other chemotherapies as it doesn't interfere with anti-cancer effects, and it can help to limit the collateral toxicity of chemotherapy. So there's been quite a lot of research on melatonin supplementation and fertility. Melatonin has been shown to improve egg quality and increase pregnancy rates with in vitro fertilization by 50% versus cycles that didn't include melatonin. And in women who had previous IVF failures, a cocktail of 3 milligrams of melatonin plus 4 milligrams of myo-inositol for 3 months improved oocyte quality and fertilization rate. And I want to note here that no maternal, embryo, or fetal toxic effects have been reported with melatonin rat studies, even with extremely high doses of 800 milligrams per kilogram. Maternal plasma levels are elevated during pregnancy, and they reach their maximum at term, and they return to their basal levels soon after delivery. Again, melatonin readily crosses the placenta and the blood-brain barrier. As well, melatonin receptors are widespread in the human fetus from early development. And it's thought that these high levels during pregnancy are thought to contribute to fetal neuroprotection, as well as starting out some rhythmicity, circadian rhythmicity. Breast milk contains melatonin, and it reflects the diurnal rhythm with low levels during the day and high levels at night. Breastfed babies have been shown to have longer sleep times than formula-fed babies, which they attribute to the lack of melatonin in formula. They suggest that mothers nurse in the dark at night, not with lights on, to ensure that they're producing appropriate amounts of melatonin in their breast milk. Finally, by the end of the first 3 months, newborns are starting to produce their own melatonin. And that's usually when the colic period starts to improve as well. So it's possible that there's a connection between low melatonin levels and colic in those first 3 months of life. Even in newborns, there's a general agreement that melatonin has a remarkably benign safety profile, even at pharmacologic doses with few significant side effects. It's been used in conditions that are related to prematurity, such as respiratory distress syndrome and bronchopulmonary dysplasia, as well as neonatal sepsis, surgical within neonates, surgery in neonates. We'll talk more about the childhood disorders, including sleep, impacted sleep and autism, and then also in children with seizure disorders. So as with adults, short-term studies in children have been shown to be safe with only transient and mild symptoms noted. But bear in mind that studies in children are done in specific populations, such as children with autism and ADHD, who also have insomnia. So it would be unethical to just do a huge trial on children to see how they tolerate melatonin or to look how it might impact puberty. So any of these findings that we have are incidental, mostly related to sleep. So note the hardy doses that are used in the literature here, ranging from 2 to 10 milligrams for children, ages 2 to 17, and lasting for 1 to 3.5 years. No safety concerns noted. It's been well tolerated and considered safe and effective in study after study in children. Unfortunately, there has been a warning issued recently from the American Academy of Sleep Medicine to alert of accidental melatonin ingestion in children, I think specifically with melatonin gummies. And you can see this increase here in 2020, 2021 during the pandemic. Not surprisingly, all of the stress that so many families were experiencing, so many people living at home together, and essential workers not being home created a lot of stress, probably impacting sleep and people turning to melatonin more, making it more available to children. Also, during this time, I wanted to throw this up on the right to let you know that not only have there been increased accidental ingestions in melatonin in children, there's also been increased accidental ingestions of illicit drugs, cannabis, opioids, and ethanol, and there's been a huge increase in those as well in that pandemic period. There's only 3 human studies that have tracked the impact of melatonin supplementation on puberty timing. And as mentioned, it's been a secondary outcome, while the primary focus was on effectiveness of melatonin and dosing for sleep. And with these 3 studies, there was really no difference in pubertal timing in the children who were using melatonin versus controls. There was one very small study where the children thought that they perceived a delay in sexual maturation, but when it was compared to their Tanner stages, it didn't really match up. So again, only 3 really small studies showing us that that melatonin did not impact pubertal timing. However, there's a brand new paper that came out in 2023, and it showed that higher serum levels of melatonin are found in boys with a constitutional delay of puberty compared to age-matched boys, and that the increased melatonin levels are inversely correlated to testosterone and FSH. So this is an important thing to keep in mind when you're working with these pre-pubertal kids, because this is when melatonin starts to decline. So there's a good chance that this decline in melatonin is one of the things that starts to trigger puberty. We don't know for sure. We still have lots more research, hopefully, to come on this. But because of this, because we know of this decline in melatonin levels before puberty, I am very cautious in giving melatonin to kids of this age. I'm cautious about giving melatonin to kids in general. I'd really like to I'd like to not rely on melatonin if I don't have to. It's been so effective, especially in kids with ADD and autism, that I would never want to take it away from someone. But I really want to caution about this drop around puberty. So when I'm working with kids, that are entering puberty, I'm going to want to explore other options. So this is an example of how to address a prepubertal boy. This is a boy without using melatonin. This is a 14-year-old boy. He's about 5'6", about 115 pounds, Tanner stage 2, with ADD and sleep terrors. Rather than giving him melatonin, I gave him 5-HTP to support that serotonin melatonin pathway, as well as B6 to support the pathway, and magnesium also to support that pathway. You could also give theanine, which is going to bind to GABA receptors, or GABA as needed. And so I gave this particular patient 100 milligrams of 5-HTP at bedtime, which did help with his sleep terrors and with his sleepwalking. And so I referred to our handy dandy neurotransmitter cascade chart here to take a look at what are the nutrient cofactors to support the pathway. And so here we've got tryptophan, 5-HTP, serotonin, acetylserotonin, and melatonin, and you can see P5P, the activated form of B6 on this pathway, as well as iron, BH4, which is supported by endogenous levels, which are endogenous levels, and they can be supported by SAMe, B3, C, molybdenum, and zinc, vitamin D. So pretty much what this usually boils down to for me is a multivitamin or a B complex or a B complex. Anyone who works with patients who are perimenopausal and menopausal will know that this stage of life has a significant impact on sleep. I was surprised to learn that there's a higher percentage of perimenopausal women, 56%, who are sleeping less than 7 hours per night versus menopausal women who are 40% are sleeping less than 7 hours per night. So remember melatonin's temperature lowering effects. It's been shown to improve sleep, mood, and vasomotor dysfunction in postmenopausal women. There's conflicting data on the relationship between estrogen and melatonin. There's been no statistical significance shown beyond age-related decline of both, how they both decline at a similar rate. Melatonin has been shown to reduce estradiol levels in cancer cells. There was one single case study in 2008 that indicated a higher level of estradiol in a female patient taking melatonin therapy, but there have been no other reproducible findings of this. So, so far we seem to think that they're safe to use together, and certainly melatonin is going to have those cytotoxic antioxidant effects. So how about male reproductive health? So treatment with melatonin has been shown to improve oxidative stress, block apoptosis, reduce pro-inflammatory cytokines, enhance steroidogenesis, and lead to normalized testosterone levels. So of course, a lot of this is going to be taking place in the testes. So why does melatonin decrease with age? Well, strangely, the pineal gland is the organ with the highest calcification rate. Why is this? Well, it seems to be very sensitive to chronic vascular inflammation, which, along with melatonin, can form bone. So this inflammation that arises from brain tissue, hypoxia, from hypertension, sleep apnea, stroke, and respiratory disorders, has been shown to promote mesenchymal stem cells, which lead to calcification. Intracranial pressure from injuries such as brain trauma, stroke, and Alzheimer's also leads to these increased mesenchymal cells. So note that there is a recurring theme here, inflammation, or what it's called over the aging process, it's known as inflammaging. So this is showing us pineal calcification in a 14-year-old, upper left, and then up here in a 47-year-old, a 62-year-old, and these are just osteons here from bone cells, just to show you how calcified the pineal gland does become over time. This calcification has been associated with Alzheimer's, MS, migraines, intracerebral hemorrhage, cerebral infarction, sleep disorders, etc., all things that are associated with low melatonin levels as well. And it's been postulated that melatonin supplementation can help to reverse this calcification. So this is saliva testing, and it's showing you morning collection. So this is when, if you look at this green area, this is the functional zone here of melatonin throughout the day, okay? So you see in the morning that it's on its way down. In the evening, it's going to be right before the dim light melatonin level at its lowest, and then it's going to start to increase, okay? So this is just some evening potential, showing us some evening light suppression, where this person has normal decreasing melatonin levels in the morning, lower than, low normal in the evening, and then quite low at night. So we know that blue light is one of the most suppressive lights to melatonin. So possibly that's playing a role. This is an example of a shift worker who tested on a day off when they would normally be asleep. So you can see that they have an upside down curve. So when testing shift workers, you want to see what their melatonin level looks like on a typical work day. And their melatonin, their nighttime levels should be tested right before they go to bed, and even if that's during the daytime. We want to see if those melatonin levels are starting to rise. This is a 14-year-old with a pattern of melatonin phase delay, which we commonly see in teens. I don't have cortisol levels on this patient. If they were ordered, we would be likely to see a reverse curve there too, where cortisol levels are low in the morning and elevated as the day progresses. So this particular patient would be a great candidate for some morning light therapy, even if she's still asleep, because we know that the retina still can register light and send that signal to the suprachiasmatic nucleus. So some light therapy, even while she's asleep, could help her get up in the morning and decrease these melatonin levels. And this is just an example of a single point melatonin ordered with a adrenal function profile. And you can see that it's just showing this nighttime melatonin level being lower than we'd like to see it, perhaps associated with that light suppression. So note that it's important to purchase melatonin from a reputable source, either physician or professional grade, to ensure that the label claim matches the potency of the product. So a Canadian study of 31 grocery store and drugstores looked at over-the-counter melatonin products and revealed that label claims didn't match up to the actual dosages within a 10% margin. So one could think that they were getting a 1 milligram dose and end up with a 15 milligram dose, or they could think that they were getting a 6 milligram dose and end up with a 0.01 milligram dose. Ultimately, there's a very small degree of risk involved in taking a chemically synthesized melatonin supplement. But if in the case of a phytomelatonin from a natural origin, you're going to rule out any contamination, which were also found in these commercially available products. And because it is oftentimes a petroleum-based product, so none of those are going to be present in a phytomelatonin, and it's possible that some of the ill effects that people will experience from melatonin are related to these potential contaminants. So in terms of phytomelatonin, its ORAC value, or oxygen radical absorbance capacity, its ability to scavenge free radicals, has been shown to be quite high compared to synthetic melatonin. Now, remember, when I'm using the term synthetic melatonin, I'm referring to bioidentical to mammalian tissue, but it just happens to have a lot of these contaminants. And in many ways, the phytomelatonin can also serve as a natural sustained release product, as it's going to need to be converted to serotonin, and that's going to help it to release or have its effects throughout the evening. So in terms of thinking of food as a melatonin source, it's better to think of food as an antioxidant source. Yes, many foods are rich in phytomelatonin, but you would have to consume so much of these foods in order to get 0.3 milligrams, which is about what the human body is going to produce in a 24-hour period. So in order to get 0.3 milligrams of melatonin, one would need to eat approximately 2,800 fresh cherries 857 cups of walnuts, 85 8-ounce glasses of cow's milk, 11 Fuji apples, 15,000 grapes. So you get the picture. A great source of antioxidants, however. So to address the question of what is the best dosage of melatonin, this is a summary of 187 references of melatonin dosing in the research on different research papers that came from drugs.com. You can see that all of these doses are on the higher end. Remember that the body produces about 0.3 to 0.6 milligrams of melatonin in a 24-hour period. So these higher dosages are going to have greater temperature lowering effects. And that could be a good thing for somebody with night sweats, but it could also lower someone's temperature to the point where they're cold at night, and it creates agitation while they're sleeping, which is going to interfere with their sleep and, of course, interfere with the melatonin being able to provide physiological benefit. So jet lag, dosages used in the literature, 1/2 to 2 milligrams. Pediatric doses have been about 2 to 5 milligrams in ADHD and autism spectrum disorder. Insomnia is usually 3 to 5 milligrams over about 4-week period. And you can see that in terms of analgesia, 3 to 5 milligrams at bedtime. One of the few times that I will use melatonin during the day in my patients is for an analgesic effect in somebody who's experiencing a lot of pain. And I'll be thinking about melatonin as an alternative to NSAIDs or some of the more, some medications that have more toxicity. I might also give it to a child who's sick, who isn't really eating, and they just need to do a lot of sleeping, and that can help to ease them, especially if they're having aches, pains, etc. This is an amazing graph that I did not make. I borrowed it with permission. I want just to share with you some of these dosages for different conditions from an extensive literature review. And you can see that, most of the dosing starts in the 1, 2, 3 milligram range and goes up, for Alzheimer's, Parkinson's, diabetes, macular degeneration, multiple sclerosis, cancer. We're looking at these 10 milligram and higher, the quite higher dosages. But you can also start lower. Things like hypertension is in the 1 to 5 milligram dosage range. Bone health, 1 to 5 milligram just over time. Interesting COVID research using 3 to 6 milligrams over a 7 to 14 day period. And then cancer dosages tend to be quite high, starting in the 10 to 50 milligram range. Thyroid health around 3 milligrams. And this is all the references for that previous slide if you want to dive a little bit deeper into some of that treatment, dosages and treatment. So ultimately, we're wanting to use the lowest dose for the shortest duration. Ideally, we're going to be sleeping in a dark environment, sleeping well, and getting that beautiful spike of melatonin in the middle of the night. But since most of us are living in the modern world and there's so much light pollution and there seems to be so much stress and interference with sleep, we really need to know how to use melatonin to our best ability. So there's 2 different forms of synthetic melatonin, immediate release and sustained release. So we're going to be using the immediate release about 30 minutes to 2 hours before bedtime to enable falling asleep. I like to use a spray or a liposomal or something for that purpose. I don't like to use a capsule. I don't want to have to depend upon the gastrointestinal tract to break it down. So if you're looking at an immediate release, you want a spray or a liposomal product or something that's going to be readily absorbed. Now remember, there's a very short half-life. So melatonin is going to work as a timing function. If you're trying to shift somebody's, well, we're going to talk about that in the next couple slides. I'm going to wait on that, the timing function specifically. If you're using sustained release melatonin, it's going to release over a 3 to 6 hour period while someone's asleep. And so that's going to help to prevent middle of the night waking. Doses in the 0.3 to 6 milligram range, 0.3 being a really nice maintenance dose. I tend to start people in the 1 to 2 milligram range, both for immediate relief and sustained relief until we get their sleep normalized. And then I'm going to try to drop them down to as low dosage as possible. So this is a graph based on a literature review to help you figure out the timing of melatonin dosing for phase advancing and delaying. So on the left in blue, starting around 3 p.m. is the phase advanced zone. So that means that dosing in this range will advance sleep for night owls. So the earlier you dose, the earlier the sleep onset will begin. The pink zone is the dead zone, which denotes a range in which taking melatonin will not phase shift. And then on this next slide here, this shows you a similar approach using light pulses to phase advance and delay the melatonin rhythm. So you can see that the green zone represents the timing when light pulses provoke the maximum phase delays of the circadian clock. And the blue zone represents when light pulses will phase advance the clock. So what I found alarming about this image is how any light at or after the DLMO will both suppress and delay the melatonin peak. So to answer the question, should my patient take melatonin? Is your patient able to avoid light stimulation after that dim light melatonin onset? If the answer is no, how can you best ensure that the patient has the exposure to the melatonin that they need to support a healthy circadian rhythm and all of the physiological processes that it supports? So only a small percentage of research subjects have reported mild side effects. Maybe we would call them a melatonin hangover. They seem to be most related to those higher dosages, such as fogginess, grogginess, daytime sleepiness, dizziness, mild headache. This is the one probably that I see the most. Nausea, mild diarrhea, vivid dreams, again, probably related to dosage and less likely seen with a phytomelatonin, and perhaps related to some of those chemicals that are found in the over-the-counter products that could be contributing to some of those ill effects. It's also been, melatonin's been shown to have a very large safety margin. And in animals, the administration has never been fatal when it's been given orally or subcutaneously. Therefore, the LD50 has been stated to be infinity. And so that's the lethal dose has been stated to be infinity. So overall, melatonin appears to be a safe medication for really all ages when used prudently. So the big question is always, will supplemental melatonin suppress endogenous production? Well, research has shown that melatonin supplementation does not impact endogenous production. There may be some temporary receptor saturation effect at higher doses where no increased effect can be observed with increased dosages. So in that case, then it's time to give the receptors a rest and then go down to some lower dosages for effect. Exogenous melatonin may improve the cell's functioning by removing the reactive oxygen species, thus increasing the cell's ability to produce melatonin. Endogenous production has not suppressed, even with 50 milligrams, has not been shown to suppress endogenous production. There's no withdrawal effects or rebound insomnia when it was discontinued. So important to always go over the factors that might decrease melatonin with your patients: the blue light, inadequate dimness when the dim light melatonin onset starts. Alcohol within 4 to 6 hours of bedtime is going to interfere with melatonin. Of course, the seasons, shorter periods of melatonin production, summer, longer in the winter. Stress, cortisol are going to suppress melatonin. Caffeine, even in the AM, best not to have any after 3 o'clock in the afternoon, but some people are so sensitive to it that even morning coffee is going to impact their sleep. And these are some medications that have been shown to decrease melatonin levels. Beta blockers have been shown to inhibit melatonin release, and NSAIDs have been shown to decrease melatonin levels and increase body temperature. So when in doubt, if you're not sure, if you want to give melatonin. We have all these wonderful ways that we can supplement and support the melatonin, the serotonin melatonin pathway, as we discussed earlier. And don't forget that exercise is a really important piece of preventing or trying to send more serotonin to the melatonin pathway instead of the kynurenine pathway. Okay, that is my presentation, and I'd be happy to take some questions now.